thank you, Dr. Martin. I appreciate that. And I just want to say thank you to our wonderful ABHIN team. Everybody here has been so instrumental and critical in making this project a success and a go today. And thank you, Dr. Martin, for your wonderful presentation. I continually learn from you, and the stories that she tells, really, that is the crux of why we're here, right? When we hear those stories and we know we're able to change people's lives and we're able to affect people's lives, and we really have an opportunity to make a difference. And that's why Dr. Martin's here, and that's why we're all here. And so, thank you. You know, my formal training is that I'm an LCSW by training. I worked in community mental health for years and years and years, and then I moved into the primary care space. And so I worked in primary care and integrated behavioral health. And I really, early in my career, we had substance use disorders separated from mental health. And so I had some experience working in the community mental health center with substance use, but it wasn't until I came to the primary care clinic, and when I got to the primary care clinic and someone wasn't following their pain contract, or someone was coming in and they were misusing their prescription or were testing positive for a substance that wasn't prescribed, that somebody like me was called in. And at that point, it was really, part of my job was to investigate a little bit what was going on with that patient and help get that patient the resources they needed to help them be successful. So at that point, I really started to realize, and I started to shift the way I thought about substance use, and really moved from thinking about substance misuse as something that was really, behaviors that we're choosing, but more, this is a chronic disease. And so that started taking me into that path. And anyway, one of the things that I think is really important, and we're going to talk a little bit today, is we cannot separate the head from the body. And for the probably first 20 years of my career, we tried to do that, and it didn't work. And people didn't get better. And we got sicker, and we stayed sick. And so I really want us to start thinking about, when we're talking about substance use disorder, that's part of treating the whole person, and that's part of our whole health. And so our healthcare system is now finally starting to move into the direction of whole health, and substance use is critical. And we know medical settings, including the emergency departments and primary care, are a critical touch point to address substance use. So hopefully today we're going to talk a little bit about the culture change, about the culture shift, a little bit about the care team, and about some things that we can do. Okay. These are our learning objectives. We're going to talk a little bit about screening, administering screening, how do we do that, talking a little bit about motivational interviewing, reflective listening, empathetic listening, stages of change, how do we engage the patient. And then we're going to talk a little about using a safety plan. Next slide. Okay, so one of the things that I think is absolutely essential when we're talking and thinking about reducing harm and substance use is meeting the patient where they are. Meeting the patient where they are is absolutely critical. And I will admit, and I've been working in this profession for a long, long time, it can be challenging to show up and to meet the patient where they are. Oftentimes, I'll just speak for myself, I might be in a rush. I might have my own agenda. I have certain boxes that I have to check off. I have notes that I have to do, and it's really difficult sometimes to just show up and meet the patient where they are, but that's absolutely critical. I hope that's one of our key takeaways today. Okay. And I think, one of the things that we're also going to talk about is abstinence. And abstinence may not be the goal of the patient. So when we meet the patient where they are, we need to know the patient may show up that day and they may not be thinking about abstinence. They might be thinking about, I feel horrible, I'm sick, and all I want is this feeling to go away. But they're not thinking, I just want to stop using. Next slide. So we're starting to have a cultural shift in healthcare, and I think that this is really an exciting time to be in the healthcare space. We know when we've traditionally looked at addressing substance use in practice, it might be the goal is abstinence, and our goal might be for that patient abstinence. However, the patient's might just be to start to feel a little bit better. One of the things we also know is the provider prescribes treatment. And so the provider offers science, knowledge, education to help the patient assess their own risk of harm and to make the best decision for them. Dr. Martin talked a little bit about that. It's also important for us to know we're moving into the space where all health consumers and patients are making their decisions on their own health care and on their choices. Sometimes they'll choose procedures, sometimes they won't choose procedures. Oftentimes, you might have a patient who comes in and I'll use myself for example. So a couple of years ago, I had a knee injury, and so I went in and my provider gave me some choices. Would you like to take some type of pain medication? Would you like to have a surgery? Or would you like to go to physical therapy and wait? And so oftentimes, we're getting this information, and as health consumers, we're making the absolute difficult but best decision for us. Same thing's happening with substance use. So I think it's really important when our patients are presenting to our healthcare spaces, they may not be ready to stop using, and that is an opportunity for us to introduce them to potential resources that are out there and available, and potentially to introduce them to peer recovery specialists who might be able to be present with them and support them through the change journey until they are ready. Next slide. So, what are the reasons that people use substances? There's lots of different reasons, and I know Dr. Martin talked a little bit about them, but I think it's important that we look at here's a few different reasons, and it's not all the same. It can vary, and so I think that's really, really important. Stress, I think stress is absolutely one of the things that's affecting use, and stress is something that can affect all of us, and so we really have to be aware of how we're addressing stress. Escaping. We want to escape from something. I don't like the way I feel. This is really miserable, and I want it to stop. I don't think that that's uncommon. To relax, to fit in, avoid withdrawals, escape feelings of loneliness, different types of pressures, career pressure, family pressure. I'm showing up, I'm doing everything for everybody else, and I just need an escape. So no, lots of different reasons. We just don't have one reason. And if we don't listen, we don't know what the reason is for the person that's showing up that day. Next slide. Okay, we talked a little bit about substance use is a chronic disease. And it's important for us to start thinking about substance use as a chronic disease. I can tell you in my practice, I have not done that probably until the past few years. Did I start thinking about substance use as a chronic disease? When I think about, high cholesterol, hypertension, diabetes, even addressing breast cancer, they're talking about, using chronic care models as a way that we could address that. And they're wanting us to do the same thing. They're wanting us to start thinking about substance use as a chronic condition. And we know with chronic conditions that they just don't go away, right? I can't just give you a medication and boom, your chronic condition is gone, but it could help manage that chronic condition. We also know that chronic conditions are are managed better at certain times than other times. And so if we're stressed, if we're not following our routine, if we're not practicing our self-care, all those things can contribute to chronic disease. And those are all things we need to be watching for with substance use disorders as well. Okay, this is a big slide with a lot of words. But the gist of this slide is right now we have an opportunity in healthcare to make a culture shift in how we think about substance use in our healthcare settings. We know that language is an absolute critical piece of changing our culture, and just from changing the types of words we use. One of the things, and this has been a hard change for me, so when I was trained, it was substance use disorders. And Dr. Martin and I have even talked about this. When we're looking for a CPT code or you're looking in the DSM-5, it is substance use disorders. However, SAMHSA is now putting information out there about the importance of using to substance misuse. So it's really important to know we have policies and we have rules and protocols such as our CPT code books, and those are not yet updated. They have not caught up to the changes of the language. That's stigmatizing, right? So it's important for us to really be aware of that and know we have moved ahead and we're still waiting for some of those changes to happen. Although I do have to say, those ICD codes sometimes are not updated the most quickly. Okay, and same with the DSM-5. I laugh. I used to teach a class using the DSM-5, and one of the things we know is as soon as the day the DSM is launched, it's already outdated, and we have a whole group of experts who are working on the next version of that DSM. So it's important for us to know opportunities like hearing from SAMHSA and HRSA about language and policies. That's really helpful, and all these other pieces will catch up. So lots of words. I'm not going to go through all of them, but just know we are in a time where we are changing the culture for healthcare professionals. Next slide. Okay, so we're going to talk a little bit about knowing when to screen, because screening is absolutely a critical piece. One of the things that's happened in behavioral health, we have not done a really good job of measuring what we're doing. And unless we're able to do that, we can't really show how are we getting specific outcomes. And if we're going to show policymakers, hey, we are making a change and this is how we measure it. We really can't do that unless we have a way to start measuring that. And so screening is one of the key pieces of how we're going to do that. There are several different types of screeners to use. In primary care, you might use different screeners than you're going to use in the emergency department. We have several screeners that are listed. For alcohol misuse, oftentimes there's a single question alcohol screener. Also, the audit C is recommended, and then the full audit. Those instruments can take a little bit of time, I will say. For substance misuse, there's also a single item question, and oftentimes I see the DAS-10 used in primary care. When we're in the emergency room, next slide, oftentimes we're going to see potentially a single question that's asked. If there is a positive, then you can go to something. Dr. Martin talked about using the Empower tool, potentially the COWS. There's several other opioid screeners out there, the RODS. So let me ask, I think this is a great time to just pause for a moment and ask. You could just raise your hand. How many of you are screening when someone enters the emergency room as part of the triage screening? Are you using opioids? I'm sorry, I didn't. Okay, any recreational drugs? And what do people typically say? No, right. I understand. Okay, and I think that's absolutely important for us to know that we are, we're asking that question, are you using any type of recreational drugs? Oftentimes people are saying no. This is a big question. How many times in the past year have you used an illegal drug or used a prescription medication for non-medical reasons? If there is a yes, then that's considered a positive and we need to do some more investigation. I think that it's important for us to be aware. Oftentimes people are not saying yes to this question. As I was reviewing the literature, one of the things that I saw from some emergency room physicians, there was, SAMHSA is doing a pilot and they have different qualitative interviews they've done. They said, well, how should we best ask this question? And what they said was, what about simply asking, do you use opioids? Oh yeah, that's a great way to ask this question. And so there have definitely been some different pilots of emergency rooms and looking at, their workflow and how are they asking this initial screening question. One of the things that they found is if we could ask this question manually, so if it's part of our triage paperwork, then we're probably going to catch more people. Even using an electronic way to try to capture this, sometimes it's not always captured in the algorithm, so I wanted to put that out there for you all. So knowing, sometimes just asking the single question as part of our information gathering in the beginning, and specifically asking about opioids could really help us identify who's using that. Next slide. Okay. So this is a screening protocol from Penn Medicine. And one of the things that they talked about, it's important to have an inclusive process. We need to empower all team members. And so as we're talking about this culture shift, we're moving to team-based care, and I think it's absolutely critical. A lot of times I like to think about, I don't know if we have any football fans, but I like to think about the physician as the quarterback, and different people on the team have a different role. And so if there is a positive, one of the things that we're seeing is oftentimes that the nurse can ask further screening questions and gather that information. That's really been helpful. So wanted to put that out there. Another critical piece of what they found to successfully address opioid use is to integrate peer recovery support. And so I think it was phenomenal for us to hear today from Dr. Martin that in her experience working in her primary care clinic as well as working in emergency rooms, peer recovery specialists are absolutely critical. One of the things that I think, and I have to give a shout out and say that I love about peer recovery specialists, is once they're connected with the patient, no matter where they are on their journey, they're there to support them, and they're able to support them in ways that we are not able to support them. Oftentimes when, I think about whether it's clinically or working as an administrator and part of a health system, oftentimes due to license rules that I have, if someone's calling me at 10 p.m. or midnight, I may not be available and I might not be able to assist them in the best way. However, a peer recovery specialist has been there, and I always think to myself, I'm so grateful that they have somebody they could reach out to, that they can connect. Maybe that's through text, maybe that's from a phone call, or just to say, hey, I'm struggling and I need someone just to listen and just to talk to. And so I think it's absolutely critical, and I'm grateful for you guys. Okay, Penn Medicine's also saying if we're screening patients in the emergency room, we need to make it really easy and we need to make it really quick. I read some literature that said if we could just have one click, that's better. The easier, the better. And also knowing that substance use continues to remain stigmatized. Misty talked about that. Dr. Martin talked about that. But stigma is alive and well, and I will admit Yes, I have stigmatizing thoughts, and it's challenging and it's hard, and I have to be aware of that, and I have to be constantly checking with myself. And if I'm walking in and I'm encountering a patient, there may be some things that trigger me more than others, and so I need to be aware of, based on my past experiences and based on my thoughts or what I've been taught. That could be affecting the way I'm looking at the patient and how I'm showing up today in the room with them. Next slide. Okay, I love this because it's an example of a workflow of how they're doing this, and it looks really succinct and really quick and really streamlined and simple. However, we know in healthcare that doesn't always happen. But oftentimes we're saying when someone presents initially to the emergency room or giving them that initial paperwork, we want to be able to ask them a single question screener. And we think of this as universal screening. One of the things that I think is absolutely essential is if we don't ask every single patient that walks in, we may not know if they're struggling with an opioid use disorder because we're not asking them, and they're not going to volunteer. So sometimes they will, but oftentimes they probably won't. So we're going to ask them a single question screener. We're going to follow up with something in this particular protocol. They're talking about using a COWS, which is a specific withdrawal screener. And then they quickly, if someone has a positive to this, they move to the nursing best practice alert, and it lets them know we need to expedite treatment, we need to contact peer recovery specialists, we need to provide naloxone to the patient, and we need to get them education and handouts and see if we can connect them. Because as Dr. Martin said, it's the golden hour if we don't have a lot of time. Typically what we've done is we've stabilized, we've discharged, and then we've left people to navigate this complex system on their own. And I don't know about you, but I can tell you for myself and just my own family members, it's really challenging to get out there and try and navigate the health system. I had a mother-in-law last year who broke her hip, and I can tell you it took me, my husband, who's also a social worker, and a couple of other family members just to try to navigate the system and make sure we're getting her the care she needs. Is she getting home health? Is she getting the medication she needs? Oh, now all the medications you were taking have been changed. Does your insurance cover this? Does it not cover this? We need you to get in, for appointments. Oh, there's, a 3-month wait or a 6-month wait or whatever it is. So this is challenging, and we know that. Okay, but if we can think about what if we had a streamlined protocol where we did the initial screening question, we followed up, did a further instrument and saw is there really struggles with substance use, and at that point we started to either notify the peer if they're there on site, or we made a phone call to them and started that referral process to see if they're available, could they come in, could they respond. Next slide. Here's an example of the COWS. I won't go through all of this. Some of you probably have this already programmed into your EMR. So, next slide. Okay, care team roles. As we talked a little bit about, I think we have an opportunity right now, as we're seeing shifts in healthcare, to know the care team plays a critical role. And so every single person on that team has an opportunity to work together to start changing the way they think about substance use disorder. Well, how does it show up, and how do we support the patient with the needs? Next slide. And with that, I'm excited that we're going to hear a little bit more today about peer recovery specialists from our expert peer recovery specialists, Megan Copeland and Sean McCown. But peer recovery specialists really have a place in the emergency room. And so I'm asked, and been asked several times on this particular project, well, what exactly are peer recovery specialists going to do? And so we're excited today because we have an opportunity to introduce them and tell you they are going to show up And they're going to mentor patients. They're going to help them with goal setting. They're going to model recovery and hope. They're going to help the patients navigate the healthcare system, because my situation with my mother-in-law, I was not an isolated incident. When patients who are struggling with an opioid use disorder are discharged, they have to navigate the system. If they want to go to treatment, somebody's going to have to help them navigate the system. If they want to get an appointment, if they want to continue with medication-assisted treatment, if they want to go to meetings, they're going to need somebody to help them. And peer recovery specialists are there. Not only can they reach out and support them maybe through a call or a text, but sometimes they can give them a ride and provide the needed transportation. Absolutely critical. Next slide. Okay, so now we're going to talk a little bit about motivational interviewing. And motivational interviewing is a technique that I absolutely love, and I think it's really important and really essential, because we know motivational interviewing in just a few short minutes can really help us start changing the direction of how the patient starts thinking about their own health symptoms and issues, and really we start guiding them down the pathway, maybe towards recovery and maybe towards thinking a little bit differently about the illness that they're showing up with. So we want to establish rapport. I always say when I walk into a room and see a patient, the visit starts the moment I lay eyes on you, right? Once we've made eye contact, we are giving nonverbal communications, and we're letting people know if we're smiling, if we're leaning in, if we're engaged. It's much different than if I'm frowning and kind of sitting back. That's not a really friendly situation. And as you saw Dr. Martin, she was up here, she was smiling, she was engaged, she was demonstrating how she's talking to the patients, and that's really critical. We have to make patients feel safe, and we have to start that trust from the moment we see them. Okay, so motivational interviewing, it is a directive, client-centered type of communication. It helps start to elicit change in behavior. It helps us look at ambivalence. Oftentimes when we're making a big decision, we're kind of on the fence. It's like, oh, I know I should be doing this, but hey, I don't know if I really want to. You'll hear we've got one leg in, one leg out. It's a little bit scary. And then empathetic listening. It's absolutely essential. One of the things, and I can tell you I've been working in the mental health space for a long, long time, and used to teach, at the U of A, and would teach about, therapeutic interventions and getting certified in different evidence-based practices, and all that's wonderful. But what I realized, probably the number one thing we can do is, as Dr. Martin said, listen. And it's hard. Listening is really, really hard. And thinking about, we've got really well-educated, highly qualified people, and if we don't show up and listen, we don't really hear what's going on with you today. What do you need from me? What's causing this? What are the barriers? Absolutely essential. And so listening is really hard, but in my opinion, it's one of the number one things we can do when we're working with people. Next slide. Okay. So empathy. We talked a little bit about empathy, establishing rapport. Empathy helps us establish trust. Empathy helps us understand the client's perspective. When they show up and they trust us and they start to tell us their story, they're being vulnerable with us, and it's a privilege for us to hear what's happening with them. And so it's important for us to know that, and my hope is that we do feel privileged when someone says, I trust you enough to talk to you about my substance misuse, and I trust you enough that you're not going to judge me. Empathy enhances communication, and it really helps us starting that change process. Next slide. Okay. We talked a little bit about exploring ambivalence. Ambivalence is a natural part of the change process. And I'm smiling as I think about ambivalence because I like to sit in the land of, I'll say the land of gray. I'm often ambivalent. I'm like, I'm not 100%. Someone says, do you want ketchup or mustard on your hot dog? Well, I don't know. I like them both. There's pros to ketchup. There's pros to mustard. And so, Misty's saying that's so true. However, I am not alone, and I think it's important for us to know when someone's struggling with a chronic condition, it's really hard for people to say, I know I should do this, I know this is good for me, however, I'm going to miss the things, the things that I have to leave behind. If I stop using opioids, these are the things I'm going to have to leave behind. And so it's important for us to know it's not just black or white. Next slide. Okay, so change. Well, first let me just say, change is hard. People don't like change, and I don't blame them. I don't like change either. Changes can be challenging. But it's important for us to know that the change is always up to the patient, right? The patient's in control. The patient makes the decision. And if the patient doesn't decide they want to make the change probably isn't going to be successful. They might change for a little while. They might even change, they might change while they're in front of you, but that change is probably not going to be long term. And what I like to tell people is, I don't go home with you. So when you make a change or when we make a plan together, that's your plan. Because I go home and I've got my plan. So it's important for us to know the change is always patient-driven. Okay. And so in motivational interviewing, there's lots of different types of techniques. Well, how do we do motivational interviewing? And I think probably a lot of us are doing motivational interviewing using that type of talk and questions, and we're not even really aware. But it's open-ended questions. It's affirmations, it's reflective listening, and it's simply summarizing what did they tell us, and it's listening to them and hearing their story. So we're going to talk a little bit about some of these principles. Open-ended questions. It invites the patients to tell their story, and we're not leading them in a specific direction, right? It's what would you like to tell me? And as patients give me a little information, I probably start to probe and prompt a little bit because I want to hear a little bit more about what's happening. And it's important to listen to the person's response. If we had more time, I like to do a little exercise where I have people, one person, ask a question, we'll spend 5 minutes, the other person doesn't talk at all, they just listen. And it's a really hard exercise, I can say, and oftentimes I'm working with therapists, and we're supposed to be the listeners. Okay, examples of open-ended questions. Someone presents, and oftentimes we'll say, are you in pain? Simply, yes or no. But exploring that a little bit, how do you feel? How often do you use drugs? An open question would, what role do drugs play in your life? Don't you want to stop using and be sober? Yes or no? Yes. If I say yes, does that mean magically today when I leave this ER, I'm going to go home and I'm going to be able to attain that? It's important to ask, what advantages do you see in changing your drug use? And that gives us the door to start exploring that with the patient. Affirmations. It's really important for us to recognize the patient's strengths, recognize what they just said to us, acknowledging positive behaviors, no matter big or small. It might, positive behavior might be simply, you showed up today. You showed up and you trusted us. That may be the behavior. Help building confidence and self-efficacy. And we must be genuine as we're talking to these patients, right? It's really important. Some other examples, you really care a lot about your health. This is hard work you're doing. That's a good idea. You're clearly very resourceful. I appreciate that you're willing to talk honestly with me about this. Reflective listening. Understanding what your patient's thinking and feeling, and then saying it back to the patient. Engaging your patients, conveying empathy. It helps us build trust, and it fosters motivation to change. It allows you to see the world through the patient's eyes. I honestly believe when we show up to any type of healthcare setting, we are in a vulnerable state because we're looking to somebody else who's typically in authority, and we're looking to them for answers, and we're looking to them for help. And so it's important for us to be aware of that, and to know that patients are looking to us to provide them with that, and they're trusting us. Next slide. Okay, some examples of reflective listening. A patient might say to you, I don't really think I'm addicted to heroin. Okay. And it might be something like, well, being told that you have a substance use disorder doesn't really seem right to you. What doesn't fit about that? I don't like being fired from my job. Being able to keep a job is important to you. I know I shouldn't shoot up, but haven't stopped yet. You know all the reasons to not inject drugs, but it's been hard for you to find the motivation to stop. So you can see kind of what the patient says and how to do that reflective listening back. And we've got this on handouts for you, so you can take it with you. Okay. So summarizing. When we're summarizing, it's really important for us to really capture pieces of the information and just let the patients know we've heard them. And I like to just interject pieces of that. It could be really simple. It could be just one or two sentences. Doesn't have to be too much. But it's a really good way if you're looking at someone, you're making eye contact with them, you're summarizing, this is what I've heard. A lot of times I'll lean in. The patient knows you've really paid attention, and for these 5 minutes, we've had this connection. Next slide. Okay. So summarizing is really important. You can see over here we've got someone and they've got some fragmented statements. They might be saying something like, I don't want to go to treatment. I'm really worried about withdrawal. My kids they might support me. I'll have to find transportation. I'd feel safer if I got help. And so you can see over here the summarization. If I hear you right, it sounds like you're not interested in treatment right now. There's a challenge in that. You'd have to find transportation. You're worried about going through withdrawal. But you also think that it'll be safer in the long run, and your relationship with your children might improve. So he's basically capturing all of the information that he was just given and repeating that back. So now I want us to look at an example. This is an emergency room physician, and she is going to be using some motivational interviewing questions as well as some scaling questions with this patient as she talks to him about his opioid use in the OR. And I think that this video was made by Yale, and it's on the PCSS website. So we're going to listen.
Hi, Mr. Coleman. I'm Dr. D'Onofrio. I'm going to be taking care of you today. So do you mind if I spend a few minutes talking to you about your heroin use?
Whatever.
So it seems like you were brought in by ambulance after a friend called 911. Do you remember any of that?
Yeah, a little bit. I don't really know what happened.
So I guess they gave you some naloxone, which is the reversal for an opiate overdose, or looks like you were taking some heroin.
Yep. I just know that my girlfriend brought me here, and I woke up here, and I'm just... she called 911, and then she just left. I just got out of this 3-week rehab program, supposedly off everything, and I guess that didn't work out so well.
Well, I'm not surprised now that you told me that, because when you're in rehab and not using, your body becomes less tolerant. And actually, that's one of the biggest risks of overdoses, being in a rehab. Addiction causes all this kind of rewiring in your brain. And when it's rewired, it doesn't get back as quickly as possible. So that I'm not surprised that you started craving and using more heroin and that you ended up here today.
Yeah, look, I guess I gotta get out of here. I'm just starting to feel like crap.
Yeah, I can see that you're starting to withdraw, but do you see some relationship or any connection between your use and being here?
Yeah, I get it, but I know what to do now.
Okay, I'm really afraid that you might overdose again. And so that you know, it has really nothing to do with your willpower, and has nothing to do with your ability to try to control it totally by yourself. I have some medication that's called buprenorphine, often known as Suboxone, that may help you with some of this. Are you willing to at least consider using some?
I don't know. I thought about doing that, but decided against it because it's really just replacing one drug for another. And I just got a new job, and I'm just not trying to go through all this again.
Well, I understand how you could think that, but it is really a medication that's been proven to be very effective to stop this withdrawal and craving. And it's like insulin for diabetics. But I can see that you are really, really in severe withdrawal. How about I just give you a little bit of the buprenorphine now, then we can have this conversation in about a half hour?
All right.
Would you consider that?
Yeah,
Okay.
if I try some treatment, everyone will be less upset with me, and it's worth a try.
Okay, great. Have you used any long-acting drugs like methadone or OxyContin or anything like that, or just the heroin?
Just the heroin. I've tried some of that other stuff, but since I'm out, I've just been using heroin.
Then I'm going to bring the nurse in and we're going to give you some, and you're going to feel a lot better. Then I think we'll be better able to continue the conversation, okay?
All right. That
All right,
sounds
good. I'll be back in a minute and she'll be right in. Mr. Coleman, you look a lot better. Do you feel more comfortable?
Yeah, I do. Thank you.
Okay, so I'd want to continue this conversation, and so what are you thinking? You look like you'd be a great candidate for this because the medication really did work. On a scale of 1 to 10, 1 being totally not ready and 10 being ready to start treatment with buprenorphine, where do you think you fit in that?
I guess a 7. I don't know. I mean, I do feel better. It would be worth a shot.
Okay, great. So you're 70% ready. That's really fantastic. What are some reasons why you didn't choose a lower number? So you must have reasons that you want to change.
I mean, I do feel better, and you could be right. It might be a good fit for me, and I just feel like I've let everyone down, and I just want to make a change. So.
I think that you didn't let everyone down. Where it's not unexpected that people don't do well trying the first time, and I suspect that this is really a great opportunity for you to get back on track again. So it would be less cravings, less withdrawal, and pretty much let you get on with your life.
Yeah, I mean, that all sounds good.
Okay, great. So let me tell you some of the things that we need to do. I need to draw a little bit of blood to look at your liver function test and make sure that your liver is fine so that we can continue this treatment. And I'm going to refer you to one of our treatment providers who's an addiction specialist here in New Haven. You live in New Haven, correct?
Mm-hmm.
Okay, good. So I can set you up for an appointment probably on Friday morning at 9 if that works for you.
Sure.
Okay, and I'm going to give you a little bit more medication of the buprenorphine now that I know that the first worked and you didn't have any complications from it, so I'm going to give you a little bit more before you leave. Is that okay with you?
Yeah, that's fine.
All right. And also the other really important thing is that I'm going to have the nurse come in and talk to you about this Narcan or naloxone kit. We really like you to learn how to use it, and so your friends and family can also learn how to use it in case you get into another overdose situation. So I'm going to have the nurse talk to you about that. She's going to give you a little bit more medication, and she's going to give you a direct appointment for Friday morning at 9 o'clock to get more follow-up. All right? And we're going to follow up to make sure that you got to that appointment okay.
All right, that sounds good. Thank you.
Okay, great. I'm really glad that you made this decision.
All right.
Take care.
Okay, so I want to ask, what are your thoughts about this video and about them starting buprenorphine in the ER? I'm sorry, go ahead. So the question is, where would the liability lie for physicians who are starting this? Oh, and I'm gonna defer to one of our physicians who happens to be here. I don't know if you have any thoughts, Dr. Martin.
As far as where's the liability lie, as far as whether they actually show up or just the writing of the prescription itself. So actually, that's a great question, and one of the big national efforts is to be able to write a 3-day prescription to provide buprenorphine for patients out of the emergency rooms. And I have some resources and stuff like that to be able to connect your providers and staff with that training, because it is really important. It is that opportunity, kind of like that golden hour opportunity to do that. And so there really isn't a liability as far as if we prescribe them something any different than we would any other opioid. We prescribe other opioids for 5 to 7 days. This just happens to be the treatment that we can initiate in the emergency room that way. And then the follow-up we would not be liable for, but hopefully when people get a few days of results, then they would follow up with a nearby provider. Sometimes they may come back to the ER and ask for more help. Does that answer your question? Okay. That is another excellent question. So actually in Arkansas, we have the state opioid response grant, and I feel like Shalinda queued this up for me. There are particular providers that are in the state. We're one of them at my outpatient clinics to provide free services to people who do not have insurance or are either uninsured or underinsured, right? They have high premiums where they can't pay for their medicines, they can't pay for a provider, for therapy and different things like that. So we can get that information to you as well. As far as I consult with physicians all across the state, and as long as they've been seen by a healthcare provider in the emergency room, they can call us and we can actually prescribe for them or get them signed up on the SOAR grant, we call it, to be able to initiate those services, which is different. You can't prescribe by telehealth a controlled substance without physically seeing them. But if a medical provider calls and does a consult, just like we would trauma, stroke, other kinds of things, they can call us. And so I do like a little telehealth on somebody's phone sometimes. The ER doctor may not feel comfortable, but they'll call me and they'll say, hey, Dr. Mark, can you help them, get them connected with your SOAR grant and help get these people some help until they can get more services? Is that?
Oh, okay. I talk pretty loud anyway, but your heart just goes out for them because they want more for themselves and you want more and you want to try to facilitate that as best you can. But to see that in a matter of 30 minutes where they can actually sit and have that conversation and they're like, wow, I didn't know that I could stop use without an intense amount of pain and an intense amount of suffering for an extended period of time. And it's really phenomenal to see how that can really completely change their perspective in a few moments.
I just wanted to say as an addict, watching that scene, I was extremely uncomfortable. From what I saw in him, I would feel like a treed cat. Anything to get this dog away from this tree is where I'm at. And, you know, he was agreeing to a lot of stuff he didn't even hear yet. So I don't want anybody walking away from that video declaring victory, because he's a scared cat. And I'll say yes to the I can't even pronounce it, the Suboxone, all right? But I'm not showing up Friday, not after that conversation. Somebody's trying to fix me. They're trying to corner me. I'm scared. Just my input.
Thank you. And so, you know, I think it's important to know medication-assisted treatment, particularly Suboxone. It's not the end-all, be-all. It's not the answer for everybody. right? It is one treatment pathway. And so one of the things that you'll hear us talk a lot about is multiple pathways of recovery. And so again, we talked a little bit about we have to meet the patient where they are. We're all individuals. We all have individual needs. We have individual strengths. We have different, situations that we're going home to. And we have to sit down, work with the patient, assess the patient, and see what's going to work for you, and what do you want to try? What are you willing to do? And no, it may be a combination of several things. This may be enough to get someone to a point where maybe they connect with the peer recovery specialist who takes them to a meeting, who takes them to some type of support and day program, or, recovery housing, or whatever it is. There's lots of different options out there, but I think we need to know when someone presents to the ER, that is a critical touch point, and it's an opportunity for us to help provide them some relief. We have a later video, and similar to what Casey said, oftentimes when that patient leaves the ER, they're just thinking about, where am I going to get my next fix? And on their way home, that's what they're going to do. And we need to be aware of that. And I don't know, and I'll speak for myself, working in, the healthcare space, that wasn't always something that I was thinking about. And so it's important for us to be aware of that. Next slide, Jenny. Okay. And I've got to tell you, we found these videos from a group of emergency room physicians out of University of Wisconsin who are phenomenal. And they've been working, some of them have been working for 30 years in the emergency room. They're sharing their experiences on working with patients with substance misuse. And so we're going to show one more short video. And I think for time, space, I'll probably go through a few more pieces. I have a safety plan. My guess is I'm going to do the safety plan later.
In the emergency department in particular, we have to be able to see where each of the patients are in their stage of addiction and the recovery process. And we have to try and meet them at that level where they are so that we can engage them in the healing process. There are some people who are in the pre-planning phase. They haven't really figured out that they have a problem. They haven't decided that they want to admit to it. They don't want to commit to treatment. So we have to be very subtle with them and try and put the pieces in place that they can use when they're ready. Then we have some people who are in the planning phase. They've recognized that there's a problem. They're starting to turn for help. Then we'll have people who are in recovery, which lasts anywhere from a short period to a very, very long window, depending on the individual. And then unfortunately, the last phase is the relapse, which can happen at times. And so for the recovery people, it's always important for us to try and support them and be positive and reinforce their good behaviors. And then in the relapse phase, we have to try to re-engage them in the process, encourage them to continue, not get discouraged, not give up on themselves, because those people are definitely at risk of backsliding into the first two phases if we don't help them.
One of the things that I've experienced in the 30 years I've been in emergency medicine is that the frustration that not knowing what to do. So someone comes in, they overdose, and you just kind of like, good luck, and here's something to follow up in 2 weeks. I think what we have now is the ability to use induction of medication-assisted treatment and give them that bridge that will get them so that they can get into recovery and can get into treatment.
They aren't not in recovery because they don't like you or they don't like your message or they have a personal problem with you as an individual. It's more because it's the disease process and the way the person is coping with it and working through it. They just haven't gotten there yet. And they will get there at some point. You just don't know. And everybody's different. I don't know if it's going to be the first time that you have an overdose and come in that you're going to recognize it, or if it's the 5th time, or if it's the 10th time. Whatever it is, all I can do is continue to meet you as a person, to encourage you to keep working through that process, and then give you all the tools that I can so that when you walk out the door, when you're ready to accept them, I've already armed you to the best of my ability to get started on that road to recovery?
There are ways that we as clinicians, but also as family members, can promote a person's entry into an engagement in treatment. So from the clinician side, being non-judgmental, presenting facts rather than opinions, and accepting the person in front of us as they are, because they have a disease of addiction.
The substance use field has really operated in isolation historically and has not been thought of as part of mainstream medicine, and that just needs to go away. I mean, this all needs to be part and parcel with how other chronic illnesses are addressed, and general health care needs to be part of that in addition to specialist treatment. And they need to be able to communicate.
Whoever has addiction for life, but just like diabetes or depression or hypertension, it could be really well managed, and people can live full lives, professionally, personally, and happy lives despite addiction, assuming it's well managed. However, if it's not treated, not appropriately managed or adequately managed, then addiction can consume one's life, because the main feature of addiction is loss of control.
Let's deal with it like a chronic disease. Let's manage it over time like diabetes, hypertension, and major depression, and not feel like we can do an acute intervention like let's pick 28 days and think that's going to be curative, because it's not.
It's not just the patient, it's their family, it's their whole support system, it's their primary care doctor as an outpatient, it's having access, again, to both behavioral and medication options to help maintain their recovery.
In there, I think a couple takeaways, and part of the reason why we decided to show this video is a couple of things. They talked about substance use disorder, substance abuse treatment has not been part of mainstream medicine. I think that's really critical. And so one of the things that we often hear when we're talking to providers and healthcare professionals, I don't really feel comfortable treating this. I don't really want to treat this. It can be really challenging. And so it's important for us to be aware of that. Part of what we do is we have a project, and we're working with some primary care providers, and we're introducing them to some of the importance of screening for substance use, starting to educate patients on the multiple pathways of recovery, starting to talk to them about starting a medication such as buprenorphine. And one of the things that we hear is, I don't really have this in my patient population. And so I think it's important for us to all be aware we do have this in our patient population. I was listening to some great webinars, and it was there were some national experts, and one of the things that they talked about that really hit home with me was about 4%, on average, 4% of our patient population is struggling with an opioid use disorder. And so when people say, I'm really not struggling with this isn't in my community, or I don't see this in my primary care practice or my ED. So 4%, on average, 4% of people in our communities are struggling with this. And so I think that's important for us to know. Another thing that one of the emergency physicians said, he said, I've been practicing emergency medicine for 30 years, and I get frustrated because I don't know what to do with these patients. And I don't think he's alone. I think that is often common, and so that's really important for us to be aware of. And I think as healthcare settings, up until now, we heard him say patients will come back, and we have repeat patients coming back, and it's because we're not connecting them with the resources, or there's not resources out there. I hear all the time, I have this patient who's come in, and there's a 6-month wait. What do we do? What do we do with this patient for the next 6 months? Unfortunately, I don't have all the answers to those questions that I'm asking myself and asking here out loud, but we do know multiple pathways of recovery are essential. We do know programs such as peer recovery specialists are critical. Medication-assisted treatment is an option. And with that, I think I should probably pause here. And And I have a piece on developing a safety plan with someone who's struggling with substance misuse. And I'll probably wait till the end of the day and share that and go over that safety plan, because I think it's nice. It gives us an opportunity of something we can do with the patient, and the patient then has a takeaway. This is my plan. This is what I'm going to do. So I'm going to hold on that. We know that change is slow. There are stages of change. We start with, pre-contemplation, maybe this is a good idea, all the way to, yes, I'm going to do this, I'm going to execute, I'm going to make these decisions. So with that, I hope a couple of our takeaways is that we start thinking about everybody on the healthcare is essential to addressing substance misuse when it comes to the ER. Listening is absolutely critical. There are multiple pathways of recovery. We're not just saying medication assisted is the only treatment or abstinence is the only treatment, but it's essential to check in with that individual and see, what does this person want to do. And we're really at a crossroads where we, as a healthcare system, here we are in Arkansas, we have an opportunity to do an innovative project, to put peers in the ED, to start normalizing the conversation, to start decreasing stigma, and to really start looking at substance misuse as a chronic disease.